Methadone, just like buprenorphine, is one of the gold standard medications for opioid use disorder. Methadone is a full opioid receptor activator, unlike buprenorphine, which is a partial opioid receptor activator. Methadone is an effective medication because of its very long half-life of 24 to 36 hours, just like buprenorphine. So half-life means it takes 24 to 36 hours for half of the methadone in your body to be broken down and leave your system. So this means it takes 5 to 7 days for one dose of methadone to leave your system. And this is why it's effective. A person taking methadone no longer experiences the highs and lows of opioid addiction and that terrible cycle of using opioids to feel close to normal and then going into withdrawal again and again and again. With methadone, a person can take one dose every day and avoid cravings or withdrawal symptoms. Like I was saying earlier, buprenorphine and Suboxone is not a full activator of the opioid receptor. Methadone is a full activator. One way to think of it is a light bulb on a dimmer switch. Methadone is the bulb shining brightly. Buprenorphine is dimly lit. The light is barely on. And why does that matter? Well, first, it means methadone can cause overdose because it fully activates the opioid receptors and can stop a person's breathing. With buprenorphine, because it's a partial activator, it's actually very low risk for causing overdose unless it's combined with other downers like Xanax, Ambien, alcohol. Second, it also means if a person doesn't have any opioid tolerance and they take methadone, it could cause some euphoria and pleasure or significant drowsiness. Now, I want to be clear that it's very unlikely for a person with opioid use disorder who's taking their optimal dose under medical guidance, they're not getting high. It's just in this situation where a person doesn't have opioid tolerance or they're misusing methadone, this is what could happen. With buprenorphine, it's highly unlikely for a person to experience intense pleasure whether or not they have opioid tolerance. A third reason why this is important is that transitioning from fentanyl to methadone is actually simple. You stop fentanyl and start methadone. It's a little more complicated than that because of some dosing restrictions, but in general, it's an easy transition. And you could you recall, or you can check out some of our other videos. Transitioning off fentanyl onto buprenorphine is actually way harder because it's a partial activator that sticks much more strongly to the opioid receptors. It could lead to precipitated withdrawal because of this, which is, of course, very uncomfortable. So the research says at adequate doses, methadone and buprenorphine are equally effective at reducing opioid use. And methadone may actually be better at keeping people in treatment. And I'd also just refer you to our video on naltrexone and Vivitrol if you want to learn how it compares to methadone and buprenorphine. But one key point is that buprenorphine and methadone are better than naltrexone at reducing overdose and deaths. With buprenorphine, aka Suboxone, you can get evaluated for treatment over telehealth from the privacy and comfort of your own home. You don't have to drive anywhere except maybe the pharmacy to pick up medication. Getting methadone, on the other hand, is frankly the opposite of convenient and private. First, you have to go to a methadone clinic, aka an opioid treatment program, in person. So it's not private. You're likely going to be waiting in line with other people. Then you have to get evaluated face-to-face with the provider. And sometimes it takes weeks, even months to get an intake appointment. And as of today, April 7, 2023, due to the COVID public health emergency, this isn't required for Suboxone. With methadone, for the first 90 days, you have to come to the clinic every day to get your dose, except on weekends. And often methadone clinics are only open in the mornings. So imagine how much time that takes and the gas money that costs if you're driving. And then you have to earn the ability to get additional doses to take home. And it takes a full 2 years of perfect attendance and urine testing in order to get monthly take-home doses of methadone. It's pretty hard. Then there's the issue of lack of access. If you decide to do methadone, well, depending on where you live, you might not even have a clinic near you. One study found that on average in rural parts of the US, it takes 40 to 50 minutes to drive to the nearest methadone clinic, while in cities it takes between 10 to 25 minutes. Imagine having to do that every day on top of working at your job, maybe dropping your kids off at school, etc. It is very inconvenient. And certain states have fewer methadone clinics than others. Wyoming has none. There are 0 methadone clinics in Wyoming. And West Virginia actually has a ban on building new methadone clinics. So, to summarize, methadone is the most regulated drug in the US. It's the only drug where federal law dictates how much a doctor can prescribe. And some states add on even more burdensome laws. For example, you can get kicked out of methadone treatment if you submit a urine that's positive for illicit drugs in many states. In my opinion, that's cruel. You kick a person out of treatment because they use the substance they're addicted to. I mean, if a person with diabetes eats some cookies, do you kick them out of treatment and take away their insulin? Yes, but it can be tricky. And you would need to work with the provider to transition over and consider alternative ways to do the induction because of the risk of precipitated withdrawal. Methadone, just like fentanyl, is actually something called lipophilic. It just means it builds up in the body's tissues. So, because it lasts so long, there's just this increased risk of precipitated withdrawal when you take Suboxone.